Hi, welcome to the NAMI presentation by NAMI Southwest Washington. My name is Deanna Lugo and I'm the Executive Assistant at NAMI Southwest Washington. I am going to do the presentation for you today. So let's get started. Welcome to SEMI. SEMI stands for Sharing Experiences and Empathy Through Mental Health Education. And as I said, my name is Deanna Lugo and I'm excited to be presenting SEMI for you and give some insight into mental health. Today we'll talk about mental health statistics, mental health behaviors, what a mental health crisis is, how to communicate and de-escalate a situation, and what mental health recovery looks like. First, a little bit about us, NAMI Southwest Washington. We are an affiliate of NAMI, the National Alliance on Mental Illness, which is the largest grassroots volunteer-driven mental health organization in the U.S. Our national headquarters is in Arlington, Virginia, and our state headquarters is in Seattle, Washington. NAMI Southwest Washington was founded in 1977 in Clark County and in 1978 in Cowlitz County. The two organizations later joined to form NAMI Southwest Washington. Our main office is in Vancouver, Washington now. We provide education and support for individuals and their families at no cost to them. We advocate and bring awareness to our community through presentations like this for companies, high schools, faith communities, and more. SEMI was created from the NAMI signature program In Our Own Voice, which you'll see a little bit of later in the presentation. Our goal is to create an environment of mutual respect and understanding. We aim to educate the public about the real-life experiences of individuals living with mental illness, and you will learn skills that promote positive, compassionate, and safe interactions. After this, we hope you start and engage in ongoing conversations to reduce the stigma of mental illness throughout our communities. In this COVID age, we are all learning a lot about what mental health is. But what are the facts? Here are some numbers that might surprise you. Mental health disorders affect 1 in 5, or 20% of adults in the U.S. In fact, 50% of conditions begin by age 14. 75% of conditions begin by age 24. Out of all of those who experience mental illness, 25% experience a co-occurring disorder diagnosis, which is having a mental illness and a substance use disorder at the same time. Many times, drugs and alcohol are used to cope with the symptoms of a mental illness. Unfortunately, the average time for someone to get help is 11 years, and the condition only gets worse during that time. Why? Because nearly 2/3 of people with a diagnosable mental health condition do not seek treatment because of stigma. How many of you have called in sick when you aren't actually sick? One big consequence from stigma is that mental health is the leading cause of missed work days in the U.S. Adults, of course, aren't the only ones affected by mental health conditions. About 16% of children ages 2 to 8 are diagnosed with a mental, behavioral, or developmental disorder. About 10% of children ages 12 to 17 are diagnosed with an anxiety disorder. Mental health disorders also affect a lot of the jail, prison, and homeless populations, as I'm sure you know. Approximately 15% of inmates have a serious mental illness, such as schizophrenia or bipolar. Getting effective treatment is much harder too, because of medication restrictions and the lack of mental health care. About 30%, which is very low ballpark number, of the homeless population has a mental health disorder. Many never get diagnosed because of being stuck in the system due to criminal backgrounds or the lack of financial, medical, and housing support. It's not hopeless though. Treatment and support helps about 80% of individuals with disorders finally get relief from their symptoms. What is a mental health condition? There are hundreds of them, literally. They impact our thinking, feelings, overall mood, and behaviors. They are the result of biological and environmental factors. They often involve feelings that everyone experiences, but those feelings persist. Usually, recovery from a mental health condition takes years, and most of the time requires medication, therapy, and a strong support system. As I mentioned earlier, 1 in 5 adults in the U.S. lives with a mental health condition, but 1 in 25 adults lives with a serious mental illness, such as bipolar or schizophrenia. As we all know, with COVID-19 and being locked down, mental health matters. Anxiety and depression are even more common now in the U.S. because of isolation, job loss, loss of loved ones, and more. Of course, there are many, many more conditions, and many of the symptoms overlap. You may relate with some of the symptoms or see them in someone you love, but please remember that seeing a psychologist is the best way to get a diagnosis. Self-diagnosing only makes getting treatment harder by creating tunnel vision or creating stigma. Just like seeing a doctor for your physical health, seeing a psychologist for your mental health should be a normal occurrence. Many times, people chalk up extreme or unusual behaviors to just seeking attention or being on drugs, but there are differences, and many times the person does need attention because they are very sick. So let's look at a few behaviors you might see in someone with a mental health disorder. Being anxious or sad is a normal response to certain situations. It's okay to be anxious or sad. Anxiety causes heightened awareness to risks around us and pushes us to react in a difficult or dangerous situation. This reaction is known as the fight or flight response. But having a mental health condition with anxiety means that fight or flight refueling is ongoing and interrupts daily life long after the threat is gone. There might not even be a threat. A person may just suddenly feel anxious for no reason. And when someone panics, it causes that fight or flight response. Sometimes, though, people freeze. They don't move, they don't speak, they just kind of black out. And it's almost like an animal playing dead until danger passes. When someone fears for their life, they will usually stop at nothing until they feel safe. They may become violent or yell at you. Understand that they feel there is no way to calm down or that the situation truly is dangerous. They'll get frustrated that other people aren't panicking. Saying, "calm down," can trigger them to get even more anxious. Trying to rationalize with anxiety can only make it worse. Continue talking in a slow, quiet voice is usually the most helpful way to handle an anxiety attack. Saying that you hear them and that you understand they are upset or scared is more helpful. You don't have to agree with them that there's danger, but agree that their feelings are valid. Their mind is firing 1,000,000 miles an hour. Thoughts and words are disorganized, and things are confusing. Many times, people think someone is just high or on meth or just being dramatic. But for them, there is a very real threat, and their life or someone else's is in danger. They may be unable to tell you exactly what is happening, or they might ignore you completely. Never raise your voice or shout commands. This only creates a danger or threat. They might be frustrated that you aren't panicked or as panicked as they are, but they will be able to calm down easier if you stay calm. Experiencing panic can look almost like a heart attack. The person can't breathe or their chest hurts. They may feel numb in their hands or over their whole body. You need to stay calm and, if appropriate, sit with them. Talk through the panic. That's what's most helpful. If you can, gently explain why the situation is not dangerous. If it is dangerous, it's okay to acknowledge that, but do not exaggerate anything more. Stick to the facts and speak plainly. Depression is more than just being sad. It's a persistent, overwhelmingly sad mood. I'm sure we've all heard the commercials. The lady is in her house looking sad and the narrator says something like, "Have you lost interest in the things you used to love?" But it is true. Daily life is greatly impaired and there is never any satisfaction or productivity. The house may not get cleaned, they might sleep a lot, they'll call in sick to work, or just not answer their phone. They may sleep the day away, eat a lot of comfort food, or not eat at all. They might lose or gain weight because of the different eating habits. They may have trouble concentrating, like if you're talking to them and even though they're looking at you, it doesn't seem like they're actually listening. They might even ask you, "What did you say?" after a conversation. Depression might be situational too. For example, you might experience depression if a loved one passes, or you have a big life change like getting divorced or losing your job. Of course, with COVID, there are many reasons to feel sad. The number of people, not just in the US, but all over the world, experiencing depression has risen because of the lockdowns, loss of jobs, loss of loved ones, isolation, and having regular routines interrupted. Depression can cause thoughts of suicide. Someone may start talking about how, "I'm a burden, the world doesn't need me anymore," and it might feel dramatic, but it's more likely they really do believe those things, at least in that moment. There are warning signs like giving away possessions, increased drinking and or drug use, or saying they're in pain, numb, or feel trapped. They might even have a plan and attempt suicide. And many times, attempts end in hospitalization or, sadly, death. The next best thing to do is talk directly about suicide. It's okay to ask the question outright. Are you having suicidal thoughts? Do you have a plan? Studies have shown that talking to someone about suicide does not plant the idea in someone's head, but instead encourages them to find support. If you talk to someone about suicide, it shows that you care about their life. Many times when you encounter a person in the middle of a depressive episode, they may be suicidal and having the worst day of their life. People who have experienced this say that when someone tells them, "You have so much to live for," or "everything will work out in the end," it doesn't really help. What helps is understanding and caring. Open-ended questions help instead of telling the person how they should feel. For example, "I can see that things are hard right now for you. What can I do to help?" Just sitting and being quiet with them can help too. They may feel like no one cares anymore, and showing that you care can change that. Warm lines are available as well. It's a phone line with a real person who will not tell you what to do or that you shouldn't feel a certain way. They are just there to listen. On the opposite end, many mental health disorders include episodes of mania. The most well-known is bipolar disorder, but many other disorders include mania or manic-like symptoms. Mania makes a person extremely excitable and in a great mood. The person might be hyperactive and usually doesn't need much sleep. They might even be awake for days. Many people describe being very social, productive, having great self-esteem. However, it's not all exciting. During a manic episode, a person might be easily irritable and overly aggressive. They may have disorganized, racing thoughts, and talk fast, but think they're being productive and making amazing breakthroughs. They may make poor decisions through risky or dangerous activities like gambling, spending lots of money, and hypersexual behaviors. Hypomania, though, is a less intense manic episode. The biggest difference is that normally hypomania does not cause psychosis. It also may not cause as many noticeable problems. The person may just get a lot done in a week and that's it. Many times, this first manic episode, usually in adolescence or the early 20s, is more of a psychosis. They have a break from reality where there are hallucinations, delusions, or paranoia. But without proper treatment and care, someone might experience more manic episodes with these psychotic symptoms. Not everyone experiences this psychosis, though. These symptoms might remind you of the most misunderstood and stigmatized disorder, schizophrenia. They may be talking fast, hallucinating. It may seem they are in another world and they don't understand what reality is. They might be talking to someone that isn't there. But it also may seem like the person is on drugs if you encounter them. And in all honesty, we know it's hard to tell the difference. In our experience, though, mental health conditions don't cause burns around the fingers and mouth like meth use does. It doesn't cause needle marks or scabs the way opium can. And slurred speech might happen with mental illness, but is more likely associated with alcohol and marijuana. Being in another world or unable to understand reality is also called disassociation. People experience this when the brain stops emitting signals and stops accepting reality, who they are, who other people are, memories, surroundings, or time. This can mean the person exhibits a different personality, or they don't talk. They might look hypnotized. Sometimes disassociation is accompanied by self-harm because the person is trying to feel something since their brain isn't registering what's around them. Many people describe feeling numb or blacking out or forgetting what happened. You may have experienced disassociation after a traumatic event like breaking a bone or being in a car accident, where you go into shock because your brain disconnects from reality. You could say things like, "This is not happening," or "This can't be real, I must be dreaming." This disassociation is common in many different mental health disorders, not just schizophrenia. People experience a break from reality where they don't make sense when they talk. Their behavior is weird, and they seem to be in their own world. They might even become a different person. Speaking of being in your own world, cognitive or thinking and feeling symptoms are experienced in a lot of different mental health disorders. Many times, people find pleasure or satisfaction in things that are not socially acceptable, such as setting fire to things, using substances to enter altered states or cope with other symptoms, saying inappropriate things just for the reaction, holding grudges and blaming others, superstitions, dressing differently, such as odd or eccentric, or constant lying and making up stories. Someone with a cognitive symptom may be overly sensitive to light, sound, people, or places. They may avoid certain situations because it causes anxiety, or the opposite, they want to create situations that make others uncomfortable. They may lie a lot about things that have happened to them, that people hate them or love them. They might lie about who they are, or that they're very, very important. The opposite can be true too. They may feel like they're always the butt of the joke and that no one ever likes them. They may look to others to make decisions for them because they don't trust themselves and they're helpless without others. You may encounter them in a dramatic situation and they might seem very likable because they're exciting and fun. The problems come when this fun, exciting person turns into a mean, vindictive person. Many with personality or cognitive symptoms are called crazy, because they will be happy one day and angry or sad the next. This is called splitting. It is hard to please them, and it seems like nothing you say or do is ever enough. It may feel like you're walking on eggshells around them, not knowing when they're going to be triggered. During an emotional moment, they may need you to just sit and listen to them. They might need to be held or hugged. It's hard to reason with the person sometimes. Don't hover or yell. It really only makes the situation worse. Be patient, stay calm, and if you need to, step away from the situation. Letting the behavior continue is called enabling, and it only shows the person it's okay to continue their extreme behaviors. The best treatment for those with cognitive symptoms is dialectical behavior therapy, or DBT. It helps people change their behaviors and control their thoughts and emotions. What is stigma? Stigma is like being stained and everyone sees it. It has to do with something other people find not normal, like having a stutter or an accent. Stigma comes from judging before you know someone. Many people describe stigma as feeling ashamed of who they are. Mental health stigma is when someone is viewed in a negative way because they have a mental health condition. People with mental health conditions may face stereotypes such as being weak or seeking attention. Stigma also comes from myths, inaccurate perceptions, or not being educated about mental illness. A lot of stigma comes from the media too. Movies and TV or the news are wildly inaccurate when describing mental illness. But most people get information and their impressions about mental health from TV and movies. In TV dramas, many of the stories about mental health show that individuals with a noticeable or serious mental health condition commit lots of acts of violence. In reality, people with a condition are no more likely to commit violent crimes than anyone else. Stigma makes it hard for people to start conversations about mental health when it's something that seems so dangerous or something that is a lost hope. Why is stigma a problem? It causes so much fear it stops people from seeking help, from their friends, from their family, and mental health providers. About 90% of people with a mental health condition experience stigma, even if not directly or consciously. Stigma can lead to teasing, harassment, discrimination, or stop someone from advancing in life, the workplace, or school. Stigma can come from anyone. Coworkers, family members, even the person themselves can cause someone to feel ashamed of having a mental health condition. It causes discrimination in jobs, education, housing, and medical care. Someone might not get housing or a job because they have a mental health disorder. For many, experiencing stigma is worse than living with a mental health condition. The way that we talk about mental health matters. Your words have impact. They can reinforce negative stereotypes and cause people to not reach out. Using words like bipolar, psychotic, or OCD to describe a person or their behavior reinforces those negative stereotypes. Instead, use person-first language. You wouldn't say, my mom is cancerous. You would say, my mom has cancer. For example, refer to people as people with mental health conditions, not the mentally ill. Say, Joe has bipolar, not Joe is bipolar. And phrases like, quit being psycho, you look so anorexic, or I'm so OCD, are other examples of spreading stigma. Sometimes people find it hard to stay connected to friends and family just because language matters. For someone who lives with depression and suicidal thoughts, it may stop them from reaching out when hearing a family member say, ugh, I just want to die sometimes. When experiencing this stigma, this is when someone needs support the most. Even if you are doing well, reach out to a friend or family member, ask if they need help with anything. Try sending a text message. Hey, I haven't seen you in a while. How are you? It can change someone's outlook on life. Many times in our own office, we have received phone calls of people who just want to talk to someone. They don't want advice or to be told how to feel. They just want someone to hear them. Being that person who listens can change someone else's life. Warm lines are available just for this reason. Some are specifically for teens, some for LGBTQ+, some for veterans, and more. They have someone on the end of the line that's there just to listen. So how do we communicate effectively after someone reaches out? We touched on this a little with the mental health behaviors, but let's dive in some more. For a person living with a mental health diagnosis, it's hard not to define themselves by it. It's also hard not to care about what other people think. Here are some statements from those with mental health conditions about communicating during a crisis or when being triggered. Please don't be afraid. I'm not violent. I'm just like you. Please understand that I have an illness. I haven't done anything wrong. Please be patient. My thoughts and actions are very slow at times. Can you help? I'm so overwhelmed with even little tasks. Stress affects my mood, my mind, and my personality. At times, everything upsets me. Kindness helps me to cooperate. Communicating during a crisis is even more important. Say someone comes into your place where you work, or a family member calls you on the phone and is yelling or talking to themselves or just crying. What's going on? They might be in a mental health crisis. A crisis can be a psychotic episode, suicide attempt, profound depression, a manic episode, panic attack, or a relapse of other symptoms. It is traumatic, overwhelming, and sometimes shameful for the person experiencing a crisis. Communicating during a crisis is most important. However you approach a crisis, remember that the brain is already in a confused, overwhelmed state. Sometimes normal, rational, or common sense ideas just go out the window. Crisis reactions range from being in excruciating physical pain to absolute numbness, being in denial of the event, confusion, humiliation, isolation, anger towards the self or others, self-hatred, and resentment. A crisis can be triggered by a range of things, but here are some examples. Emotional, like being rejected, experiencing grief or fear, or feeling inferior. Physical, like experiencing unwanted sexual advances or touching. Verbal, like people speaking to them in an argumentative, parental, or authoritarian tone. Threats from others, for example, someone saying, "I'll call the police," or "calm down," or "stop," or "I'll leave." Sounds like loud noises, yelling commands, fireworks, or gunshots. Locations, that can range from being in a specific home, at a workplace, in a courtroom, stuck in a small space, or being in a church or a school. Social situations, like being in large crowds, having to leave the house, being isolated from others, specific or in general, men or women. Financial problems like money issues or gambling. Other triggers include specific people, colors, words, or odors. Remove the triggers that you can get rid of. If you need to move the person, do it slowly. Make sure it's not against their will. Once de-escalated, a person will need a safe place. Sometimes sleep, someone to help provide basic needs for a while. Taking a break from daily responsibilities is sometimes needed. Taking medication and regular therapy are also ways to support the person back to recovery, and it may take days or months. It may take a stay at the hospital or an inpatient facility. Most importantly, while interacting with a person in crisis, trust your own instincts. Safety is always the most important rule. If your instincts say to back away or call someone else for help, listen, act upon them. Next, assess the situation. What is the person doing or saying? Are they destroying property or hurting themselves? How is the person speaking? Are they yelling? Are they not talking at all? Or are they not making sense when they talk to you? To de-escalate a situation, remove people from the sidelines. Use slow and deliberate movements, respect the person's personal space, and remain calm. Remember to always be patient with a low, calm, welcoming voice. Talking about intimate, personal struggles is hard. Many mental health conditions cause confusion already, so short, clear, direct sentences are best. Some other techniques might include keeping the stimulation low, like turning down the lights or shutting the door to keep sound down. When approaching someone, make sure to not hover over the person or make threatening gestures like waving your hands or puffing up your chest. Show the person support instead of dominating over them and stop others from rushing over. Help the person take deep, slow breaths. Breathe in and count to 4, breathe out and count to 4 with them. Remind them you are on their side to help find a solution. Give them options or ask a leading question like, what is something that makes you calm? Would you like some water, fresh air, space? Listen to what they're saying, even if it doesn't make sense, so you can answer their questions if possible. Never accuse them or criticize them, but answer appropriately without lying. If you're caught in a lie and the person realizes, the situation may escalate. Make eye contact, unless that is triggering or stressful for them. Help them by refocusing their attention to a task or other talking subject. Speak slowly with a calm voice and polite. Say please and thank you. If you think it's appropriate, smile. If you can't help them, call a crisis line or the mobile crisis unit nearest you and explain why you can't help or provide service. Remember, it's not their fault or yours that you aren't equipped to help in the moment. If someone else can relate, ask them to help. Keep conversations simple, focus on one topic or direction at a time, and guide the conversation back to the original topic if needed. And using physical means should always be your absolute last resort. Going through a crisis can be terrifying, but many times it leads to someone getting help. Many people associate the word recovery with substance use, but mental health recovery is possible too. Just like with substance use, people can recover from a mental health diagnosis. Of course, recovery looks different for everyone, but some common outcomes are achieving a full and satisfying life, getting back to the normal daily activities, skillfully handling mental illness symptoms to stay stable or able to de-escalate yourself, returning to the community and having a social life, thinking and speaking positively, sticking to a medicine regime that works, which doesn't always mean taking medication, being able to start stable and healthy relationships and continue staying stable and healthy, feeling more in control of your emotions, or at least able to regulate them throughout the day, being comfortable with yourself, even liking yourself and having confidence, and having hope for the future. You heard some ways that people can stay in recovery. Nope, that is not what I want. NAMI Southwest Washington offers a Steps to Recovery course called Strive that helps build skills that help people get into recovery and stay there. A WRAP plan, which stands for Wellness Recovery Action Plan, also helps keep you on track towards and in recovery. Recovery is possible. Having a mental health condition doesn't mean you can't succeed. So you might be asking questions like, so what does it feel like to have a mental illness? How do you get treatment? Is it actually possible to live a fulfilling life? So I'll try to answer those questions with my own personal story of living with a serious mental health illness. So, hello again. My name is Deanna. I'm the Executive Assistant at NAMI, National Alliance for Mental Illness. I am 30 years old. I used to be a theatrical costume designer and seamstress around Portland and the Tigard area before moving to Vancouver. I got married about a year ago, and my husband and I have a cat named Kyla Marie Wren. The first few days of my life were very physically traumatic. I was born with Tracheoesophageal Fistula. In layman's terms, my throat ended in a pouch, still connecting to my lungs, but did not connect to my stomach. I could breathe, with difficulty, and food would be rerouted to my nose. I had 3 surgeries to repair it in the first 3 months of my life. Still, my throat would close without any muscles to hold it open. In fact, it still does. I was left with 3 large scars on my torso. One across my left breast, one from the middle of my chest to my belly button, and one from the middle of my back to my right armpit. I developed more issues when I was about 13. I felt alone, different, unable to fit in, because I couldn't just run. My respiratory system could not handle it after so much trauma. Kids would point at my scars when I wore a bathing suit or a tank top, and I began to feel more than just sad. I was desperately troubled and distressed. I did not ask for help because I thought my parents would punish me. And I ended up binging and purging, or bulimia. And when my mom found out what I was doing, she told my dad. He prepaid for exactly 15 weeks of Christian therapy, telling me that I would be better or normal afterwards. I attended for probably about 6 weeks when the counselor explained to my parents that I needed a higher level of care. Reluctantly, my dad sent me to a day treatment center right before my 17th birthday. My parents were required to attend a few counseling sessions with me during this time, and they began to see that maybe just prayer and hope was not enough to help me live a normal life. I did recover. I was able to graduate high school and generally was successful after that. 2 weeks before I began college, I went over to a coworker's house. I was interested in him and thought that he might want to date me if I came over to hang out and get to know his family. Instead, his cousins gang raped me that night. They had actually set it up in advance, knowing that I was interested in him. He had tricked me. So from there, I obviously spiraled out of control. For years, I never told anyone what had happened. I pushed my feelings away. I yearned to be loved and desired and accepted. So I began letting anyone who wanted to use me into my life. And I called this abused love. To deal with the event and the constant, rapid, overwhelming emotional fluctuations, I self-harmed in many ways. I relapsed and began binging and purging again. I cut myself, banged my head on my bedroom walls until I passed out, and at one point held a bottle full of painkillers in my mouth, waiting for the courage to kill myself. And it never came. The previous reaction from my parents, well, 15 weeks and you should be good, haunted me. I was overwhelmed, constantly. I could cry, laugh, and punch a wall in anger all in the span of 5 minutes. So I began smoking weed, drinking to self-medicate, on top of taking medications my counselor had me on, which could cause seizures. And yes, I was in counseling this whole time. My counselors usually chalked up my outbursts of sexual promiscuity, violent anger, or reckless happiness to attention seeking. I was still diagnosed with depression and general anxiety with panic attacks, but my extreme behaviors were thought to be just for attention. When I was about 20, I told my counselor I had been having suicidal thoughts, and we agreed that I would admit myself into the ER. I was put in a regular ER room and left alone. I don't know for how long because I blacked out. I was still awake, but my mind had shut off because of the overwhelming emotions. I didn't know it at the time, but this is called disassociation. I felt like I was outside of my body, and I don't remember what happened to me. And this happens while self-harming, when anger became overwhelming, or during rape. And a janitor passed by the room while mopping the floor and asked if I was okay. I remember this very well because it was the first time I had been asked. I cried no. I curled back into the corner of the room. A nurse came over and she pulled me out from under the counter and said that I have to be visible. And I said, I thought, to who? Only the janitor knows I'm here. So after what felt like hours, a psychiatrist came to the room. She was soft-spoken, looked me in the eyes, held my hand. She said, I think you have borderline personality disorder. Here is a treatment center that can help. Shortly after that, I was accepted to the Portland DBT Center. DBT, or Dialectical Behavioral Therapy, is a relatively new therapy that focuses more on changing behaviors and patterns rather than just talking about things. It is usually one of the last chances for people diagnosed with borderline personality, or BPD. Symptoms include irrational fear of abandonment, unstable relationships, unclear or shifting self-image, impulsive and self-destructive behaviors, self-harm, extreme emotional swings, chronic feelings of emptiness, and explosive anger. Once I read about this disorder, I felt a lot better. It was a relief to have a name to the distress and overwhelming emotions I was having, and I had a period of stability and mental wellness during and after DBT. However, I relapsed around the age of 22. I began using drugs and alcohol again to keep my emotions balanced. I stopped using my skills, and in a few years I was going to school, work, and driving under the influence. I do not remember a lot of what happened during this time because my mind was very far gone. I slept around, I was in car accidents, I lost jobs, I almost didn't graduate college, I spent most of my money on alcohol and drugs, and a lot more happened. All these are symptoms of BPD not being taken care of, and I did this for 6 years. I was finally arrested for driving under the influence in early 2018. When I got arrested, it was a very interesting experience because not only was I very intoxicated, but I also had a complete meltdown and breakdown in the back of the cop car. I began hitting my head on the door, crying, yelling, and overall just having an emotional breakdown. I went to court. I spent time in jail. I paid lots of money because I stopped taking care of myself and I lost control of my disorder. I was court ordered to attend a rehab program, which I did, and was diagnosed with PTSD. I stopped talking to friends who used and abused drugs and alcohol. I moved away. I made new sober friends, and the support system that I have now helps me not only stay sober, but also stay in control of my BPD symptoms. I've had to come to accept that I just have to be sober to live my life. I also decided that I actually want to live my life and not just survive. Being organized, having a plan, and journaling are the most helpful skills to me. I can now balance my emotions, stop most of my panic and emotional attacks before they happen, and enjoy my life. I make sure that I always have time for myself to sit and just breathe, feel my emotions, and then let go of them. If I've made a list and I've done everything I can for a situation I'm trying to fix, then I know I've done everything and I let go of it. So much of learning to live with a mental illness is to let go of those overwhelming moments and emotions. I am still a work in progress, every day, of course. My husband is amazingly patient with me. He knows when to give me space, when to help me confront my emotions. My cat helps me calm down. My job helps me know I can be successful and that my life is not meaningless. Mental illness does not stop you from living. It just gives you a very different perspective on life. And I've always said that because of all my medical and mental issues, God made it so I have to slow down and smell the roses. It's too bad I'm allergic to flowers, though. Thank you so much, and hopefully this has been helpful for you. If you ever have a question, you can always email us at info@NAMI SW WA.org or call us at 360-695-2823. Thanks.